Welcome everyone to today's webinar, How is the Surgical Services Market Changing? Top 5 Surgical Service Trends in 2021. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. And if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's speakers. With us today are Leslie Basham, who is the President and CEO of Surgical Directions. Leslie is passionate about partnering with healthcare executives to improve the health and well-being of the communities they serve, while profitably growing their organizations. Leslie is responsible for building meaningful relationships with clinicians and administrators, ensuring high-quality work and insights, and delivering measurable outcomes. With us today is also Dr. Joshua Miller, who is the Physician Managing Director at Surgical Directions. Dr. Miller has more than 30 years of experience in healthcare leadership, including profit and losses responsibility, as well as hospital, surgical, and medical group consultative services. Dr. Miller works with hospital and practice leaders to integrate perioperative efficiency, best practices, compliance, practice optimization, and physician and hospital staff satisfaction and well-being. Leslie and Dr. Miller, thank you for being here today. Leslie, I'll turn the floor over to you first.
Great. Thank you, Morgan, for that wonderful introduction. As she mentioned, I am Leslie Basham. I am the President and Chief Executive Officer of Surgical Directions. I'll just take a minute to tell you a little bit about who we are so you understand where we're coming from in these trends and the background that we bring. So Surgical Directions is a specialized healthcare solutions firm. We really focus on consulting, leadership, placements, and digital and analytics solutions within the perioperative and anesthesia space, pretty much as our company name implies. We've worked across 400 different healthcare clients nationally across the United States, with over 35 years of experience with Surgical Directions, and with generating around 10 times return on investment for our clients with the type of work that we do to help them achieve their goals. We are based also in Chicago, Illinois, but as I said, operate across the country. So today is really about what are we seeing in surgical services for 2021. 2020 was an eventful year. It's created a huge amount of change, and it's accelerating some trends that we've talked about in 2020 and creating some new opportunities. And that's what we want to get to here. So we're going to talk about these 5 trends, and I encourage you to ask questions as we go through, and we'll have a great dialogue at the end to address some of those concerns, or you can reach out to us directly. So here are 5 trends we're going to talk about. We'll go into a bit more detail about each one of these. So first, that seamless experience. This is what patients are expecting, especially with this, the very complicated surgical journey. And so how do you create that seamless surgical journey for your patients? The accelerating shift of cases or surgical volume to an ambulatory setting, what we're saying ASCs here, ambulatory surgery centers. So a shift outside of the hospital to ambulatory settings. Also an increase in transparency, particularly with price transparency. Unfortunately, compression of margins for particular players within the surgical services space. We'll talk about that and what they are and how to respond. And also the data-driven operating rooms. Really cool stuff happening here. And we want to talk about some of the things that we're seeing and how to really capitalize on those particular opportunities. So I'll turn it over to my esteemed colleague, Dr. Josh Miller, to talk about the first trend.
Thank you,
Go ahead, Josh.
Leslie, and thank you, Leslie, and welcome everyone to the webinar. We appreciate you being here. The first trend that we're going to talk about, as Leslie discussed, is the seamless patient experience. And so there's been a lot of technology changes and a lot of internal hospital changes to improve that seamless experience. The analogy I use is 10 years ago, we all probably went to the bank to deposit checks. And now we have an app that we can use to deposit our checks without leaving the house. It took us to get to the fifth slide before we started talking about COVID, but unfortunately COVID has had an impact on healthcare in a lot of ways. Some of it has been positive in the sense that telehealth and virtual visits have increased dramatically. And if you look at this slide in particular, and you look at this left side of the slide, you'll see that older Americans are embracing telehealth. And that's important because older Americans are frequent users of surgical services. So they're starting to understand the concept of the pre-anesthesia visit may be virtual, there may be an app for post-op visits, et cetera. So this is a very important first trend we're seeing. The data for 2020 is really interesting in that in April, Epic data suggested that this was multi-hospital Epic data, suggested there was about a 69% increase in virtual visits across Epic data. It sort of whipsawed around because by July, and as the initial first wave subsided, the increase in visits was about 21%. But overall, MD Live new bookings through virtual visits has increased about 300% 2019 from 2019 to 2020 year on year. And so this is a very important first step in engaging the patient in that seamless experience. The consumer's use of technology for health and fitness purposes has really increased across the entire spectrum of healthcare. So, for example, apps, monitoring. I bumped into a friend of mine over the weekend, and she is the director of a virtual COVID hospital for a large healthcare system. And she told me she had about 8,200 patients in their virtual COVID hospital at this point. The vast majority of it is through app monitoring. About 200 of those patients have more significant day visits from nurses, but the other roughly 8,000 are using apps to measure and monitor things like pulse oximetry, temperature, et cetera. And if there's a change from set variables, then they are converted either to nurse visits or to a visit back to the hospital. This is a dramatic change, and that technology and all that virtual usage of medical data is translating to the hospital surgical experience. So surgical services can use a lot of different innovative technologies, processes, and governance to create the seamless patient experience. And we've talked a fair bit about the virtual care solutions, patient engagement tools, virtual PATs, virtual reality for surgical preoperative visits, the use of AI in radiology studies. For example, a neurosurgeon may use MRI scans and virtual goggles to plan their surgical approach to a complex cell-based surgery, post-operative phase and long-term recovery, including remote patient monitoring devices and virtual follow-up visits. And I'll give one recent personal example. I had a little thing taken off the back of my neck that wasn't a big deal. The surgery went fine in the office. The post-op visit consisted of an app and a picture of the scar, which was fine, and that was my post-op visit. This is dramatically different than what we were doing 2 or 3 years ago. So in addition to the innovative technology, an important part of the seamless process is what we do behind the scenes for patient preparation. So there's the forward-facing patient experience, and then there's a lot of the work that's done behind the scenes, if you will. And that includes assessment and triage of the appropriate patients for the appropriate location, evidence-based protocols, education of the patient, and transition care planning. We do all that for the patient. In the intraoperative phase, we want the right patient, the right personnel for the patient acuity and surgery and also the right location. We want to have our supply chain up and running. So for example, a patient having a left total knee replacement isn't waiting in the preoperative area because the vendor brought a right total knee. Operational efficiencies to reduce wait time. So you want that seamless experience from when the patient parks their car at the door of the hospital to the point where they go through pre-anesthesia, wait room, to the surgery, to the PACU recovery room, and either to the floor or home. You don't want holdups along the way in that supply chain, if you will. And so as part of that, it's important to have reduced variation throughout the entire surgical process. And then again, post-operatively, we want to be talking about the right level of care for the right surgery. And again, that will feed into my next section when we talk about ASCs. We want integrated pain management and ERAS protocols, which is early recovery after surgery. We've really changed a lot of what we do to manage the patient, so a lot more patients can go home. They don't need to stay in the hospital strictly for pain control. And then prevention of complications, of course. In the long-term recovery phase, we want coordination of discharge plans. We want to really work on that behind the scenes again so that the patient benefits from this but isn't directly having to plug in and do it themselves. Transition to appropriate level of care, as I said, and then rehabilitation, home rehabilitation, and return to function and reduce variation in that environment as well. So as we've talked about, technology is important, and the move to do all of these structural things behind the scenes is very important for patient care. What we have seen in our 400+ hospital engagements is that establishing a patient-focused operational governing body to ensure seamless patient experience is vital to the patient experience. It's also vital to hospitals as far as the ROI on the hospital experience. You improve efficiencies, you decrease staff waits, and in order to do this appropriately and effectively, this really needs to be a physician-led, physician-run committee that is administered or approved of and administered by the senior leadership of the hospital. There really are 4 important silos or groups in this committee, including the surgery champions, nursing leadership, anesthesiology leadership, and senior hospital leadership. Again, it's physician-led with a large percentage of clinical participants, administration-sponsored, controls access and operations. It's really an operations committee. It's really the board of director of the operations of the hospital surgery center. The governing body builds trust in the sense of joint ownership. It establishes the vision for surgery, creates a dashboard. It develops an efficient physician and patient-friendly process, and importantly, creates protocols for enforcing behavior of the physicians and staff. And physicians tend to talk to other physicians in a very direct way, and so a lot can get done if the surgeons and anesthesiologists are leading this committee. And it focuses on strong collaborative leadership. So 5 important questions that you need to answer for your organization as you implement seamless patient care. Have you defined your virtual health strategy? And that virtual health strategy should include, obviously, medical care, but importantly, surgical care. How will you decide what is virtual versus in person? And the Surgical Services Executive Committee will have a lot of input into that, and it will help you improve patient experience and satisfaction, again, by utilizing virtual care. Have you developed a multidisciplinary surgical governing body to drive processes of the seamless patient experience? What performance and goals and metrics will you measure to drive these results? And have you picked for physician and staff champions that are engaged now and will build engagement with their colleagues? So moving on, we're going to talk about a trend that a lot of people have been talking about for a long time, but in 2021, we're going to see a dramatic increase in the growth of ASC versus hospital surgeries. And there's a number of reasons for that. First of all, there's a lot of mixed surgery, if you will. So there are some surgeries that are done as an inpatient or as a hospital-based surgery, and also as an ASC-based surgery. And those are on the column or the chart on the left. Those are the darker blue surgeries. There are a certain number, for example, cardiovascular surgeries that, at least with current technology, will not be moving to the ASC, but ultimately, 25 years from now, that may look very different. There's a large bundle in the middle for cardiovascular, musculoskeletal, which includes orthopedic, neurologic surgeries, and GI procedures that can be done inpatient or same-day outpatient or in an ASC. We suspect that the vast majority of those dark blue in that chart on the left will move to the black on the right, which will be only outpatient surgeries. Recently, there was a McKinsey report where about 300 administrators were asked what they were doing to prepare for a shift to outpatient care. The good news is many are looking at opportunities for outpatient care. My perspective is more needs to be done from that hospital administration perspective, because if you're not in the game, you're going to lose the game. So it's really important that hospital leadership find ways to partner, find ways to build a footprint in the ambulatory world. So the shift to procedures performed in the hospital to ambulatory centers is gaining momentum due to a lot of factors. There's market factors. For example, very importantly, and I'm going to skip to the bottom bullet there, CMS changed the rules. So the change was final in December of 2020, and it eliminates inpatient-only lists, there was currently a list of certain surgeries that only could be done in an inpatient setting. And that list goes away. There's essentially not going to be a list that's determined by the government. As part of that, 266 musculoskeletal/orthopedic services were removed from that list in 2021. So there's going to be a dramatic increase in orthopedic, in particular, ASC-type procedures this year. There's increased reimbursements for some select procedures. Insurance is incentivizing patients and surgeons to choose ASCs. And so if you have and Leslie will get to this in a little bit, but if you have a high deductible HSA plan and your costs are going to be somewhat out of your pocket or completely out of your pocket, you're going to look at the value of hospital-based procedures versus ASC procedures. There's facility factors. So in general, ASCs are very efficient. There's a very low case cancellation rate, generally less than 1%. Hospital case cancellation rates, unfortunately, are higher than that. As we talked about, there's a decreased cost of elective time. Currently, hospital-based OR runs between $60 and $100 per minute. ASCs have less overhead overall, and so less cost associated with it. And there tends to be a specialty focus at the ASC. So if you have an endo center or an ortho ASC, that really drives efficiency. You're focused on one thing, and doing it repetitively with decreased variability. The other factors are physician factors. So 74% of ASCs are at least somewhat driven or owned by physicians, meaning they have a personal stake. They have money at the table, if you will. And so they want to run a very highly efficient facility. And that collaborative culture that we talked about in single specialty or small number of specialty ASCs drives a collaborative culture. So for example, if you have a pain group and an orthopedic group working in one ASC, there's a lot of collaboration there. And then there's the patient factors. It's easier to transition to home now, as we talked about with ERAS and pain management techniques, lower co-pays, as we talked about, and frankly, the patient's fear of COVID-19 and going to the hospital. That is real and remains a problem for us, at least for the first half of 2021. So as we transition to the procedures to ambulatory care, and this transition grows, hospital leaders in particular need to be thinking about the following questions as they move forward. Number 5, how can we create an ASC-like experience in our hospitals to maximize efficiency? And that goes to the seamless patient experience, to utilizing apps, to making our hospital-based surgeries ASC-like, in that they're very seamless and easy for the patient. Patients are looking for easy, seamless approach to their care. How do we right-size facilities in our geographic footprint and target patient populations for our ambulatory network? So that means exactly what it says. Do we have certain rooms that are more patient accessible, more patient friendly? They may not be built right in the main operating room suites. They may be off to the side. But how do we target that geographic footprint and how do we target the patient population? How do we advertise? How do we market that our experience is going to be seamless and easy, and demonstrate it? And what is the strategy for engaging and partnering with physician investors to create joint venture ASCs? This is really, really important, particularly in markets where hospitals may not employ physicians, where there's a fair number of private physicians. Those private physicians will compete directly with the hospitals unless we find a strategy to work together in a joint venture. And again, what performance goals and metrics and what incentives, importantly, are needed to drive the results both in our hospitals and associated ASCs. And those are tied together. So the performance metrics are tied to financial incentives in this environment. And then what is the optimal approach to align physicians and ambulatory care networks for best-in-class decision-making strategy and operations? And this goes to the ASC model where physicians are at the table. It goes back to the Surgical Services Executive Committee for the hospital-based surgeries. If you have physicians at the table who are incentivized, have some operations control, and understand that their decisions will impact their efficiency and their productivity, they will sit at the table and they will be very involved. So those are the first two trends. I'm going to turn this now over to Leslie to continue with the next three. Leslie?
Great. Thanks, Josh. So the third trend is around transparency, and we're really going to see a pickup of this or an acceleration of this within 2021 due to recent policy changes and the continuation of a few trends that really have existed over the last few years. So, for example, as of January 1st, 2021, CMS also introduced the hospital price transparency rule. So Josh talked about the site neutrality. This is about really putting some teeth behind hospital and care facilities' mandate to show price transparency and not just have price transparency for the hundreds of procedures that are listed, but also what needs to be made transparent. What are those cost factors that need to be there, and the direction around how that can become more consumer digestible, consumer friendly with that information. So, you haven't looked into the hospital price transparency rule yet, I encourage you to do so. There's also a lot of consumer organizations that are actively pushing not only the increasing demand, whether it's voluntary or forced through a high deductible plan, but really interested in understanding the cost, being able to digest it, and having the actual cost match what was expected in the beginning. And of course, as payers and health insurance are seeking really to reduce the overall cost of care while also ensuring high quality, there's additional steerage that may be occurring, or member navigation to those facilities and those providers that have a more cost competitive solution or procedure or product compared to other institutions. And I think payers are likely to be doing more of this in 2021. And so it's important to be cognizant of that as you think about your own institution and your rates. So speaking of health insurance, what's really driving this, right? If you look at the increase from 2006 to last year, the high deductible health plans is growing, right? It used to just be the small firms because it helped to reduce the pressure on the employer. Now it's everyone, right? The large firms are doing it even more frequently than the small firms. And with that, it becomes like an out-of-pocket retail transaction for many patients, right? So these high deductible health plans are, $5,000, let's say, is their deductible. Well, that becomes an out-of-pocket transaction for much of their health care. And when that happens, just like everything else, Josh talked about banking, but any purchase of a product, people shop price. That is the number one thing that people shop on across almost every single industry. And if it's price, then what do you do for your facility, for your product, to help make sure that you're delivering the highest value care while still remaining competitive in the surgical environment? So, and this trend is expected to continue in 2021. Clearly, with the unemployment rates within 2020 as well, there's shifts there as well. So what are the provider and patient factors? And transparency is a wonderful thing. It comes at a cost for a couple institutions or for people that we just need to be aware of and know how to respond to. So the pros is that some institutions really already have this figured out within surgery, right? So total knees, total joints have been in bundles for a while. There's a clearer sense of what does that total cost look like for that particular procedure, how you compare to others. The more you're in these value-based care programs, the more you're ahead of the curve where others may not be able to even be able to pull this together, right? Surgery is complicated. There is a lot of pieces to surgery. You know, there's anesthesia and the surgeon and PAT and post-op and all these pieces. And so it's harder to do. So if you figured this out and you understand your positioning relative to your patient's other options, it's a great thing, and you'll be ahead of the curve and have a chance to be able to serve more patients. We also can learn from other areas of the healthcare, right? So transparency became, you know, very popular and very prevalent in things like imaging, labs, primary care. You know, surgery, given its complexity, has taken a little bit more time to really get teeth behind it. And so, you know, we should always be learning from other people across the care continuum and understanding how they are doing that. On the patient positive side, you know, their surgery is already an incredibly stressful moment for any patient, right? Any of you who are listening who are caregivers, you're very aware of this. And it's already very stressful. And then the cost of surgery is this additional stressor that really creates an issue. And, you know, the good hospitals that have a good surgical authorization process and financial responsibility, and those discussions are happening. But having the patient understand that out-of-pocket cost prior to the surgery and having that expectation be, you know, met at the end when they're actually paying for the surgery, it's important. It helps to relieve some of those. They know what they're getting into, and it lets them be a more informed consumer. And some people get really agitated when people talk about patients as consumers, but I think with this high deductible health plan and some of these trends we're seeing with the digitization of health, these patients are increasingly becoming consumers, and so they are shopping healthcare. They're shopping facilities based on price and quality, and it's important. You know, it gives them options. It gives the patients greater control of their health. On the con side, there's also increased competition, right? As soon as that additional transparency is out there, people can and will likely potentially shop on price. And it's complex within surgery. And there's a lot of different vendors, right? Sometimes anesthesia is different. The surgeon is independent. Our hospital, it's very complex with surgery, and so maybe a little bit more challenging to pull off. And with that increased competition and the push for high quality, lower cost care, this will create potentially additional margin pressure on the providers. On the con side, the patients are, you know, this is very valuable information, but it's complex. It's hard to know. It's hard to find. And so are we educating the patients on what this information is, how to use this information, and how to make the best decision for them? These decisions are often not black and white, as we know, and help them understand, you know, many people shop on price, as I mentioned. Is this particular procedure something they should be shopping on for price, and how can you help patients understand, you know, why certain institutions are more or less than others? Are they getting the right care? And just help patients make sure that they're making the right decision for them, and that is very personal. So what are some of the questions that we should answer, right? So make sure you understand your product or your service and how it compares to your competitors. And preceding this, right, who are your competitors in this space? That changes a little bit with information availability and how much people travel now for care. What price or market differentiator does your product or service warrant? So if you are more or less, why? And be able to speak to that. How is your organization, can you deliver this information? And not only deliver it, but deliver it in a consumer-friendly and accurate way, and not just to, existing or prior patients, but to those who are shopping. And has your leadership team considered the opportunity cost of not following it? Like I said, transparency has been around in various flavors for a while now, but how are you competing? What is being done? And is there alignment across the organization there? And how do you use it to your advantage, right? It is going to be more prevalent. It's not avoidable. So if this is really what's happening and where, how healthcare decisions are being made, then what can you do to make sure that you are making the most for your organization and for your patients in this environment? Next, thinking about margins. So there's a lot going on in the market that is creating some margin pressure and compression. The biggest thing, Josh said we waited till slide 5 or something to mention COVID. That's clearly an important part of 2021 as it was in 2020. So last year, according to HHS, there was $178 billion of CARES Act provider relief funding, which was wonderful, and many institutions took advantage of that. However, the estimated cost of COVID to hospitals, this is just to hospitals according to the AHA, is $323 billion, right? So there's a mismatch there. And hospitals already, as the top of the slide states, have very thin margins compared to other industries, and many hospitals are nonprofit, but there's very little room for error, and the postponement of elective surgery, created a big dip in surgical volume, obviously, and therefore the financial health of the institution. We track this with our clients, and on average, our clients, I think, lost about 17 to 22% of their revenue, of total case volume last year. And some others fared far worse, some a little better. It depended on your region and how you were handling your region of handling the postponement of elective cases and the definition of elective cases. But it created a big financial hit. And we, at first in March and April, we were thinking there'd be this huge surge where all those patients would have come back. But we didn't see that, right? COVID kept going, still is going. We didn't see that surge of cases coming back later in the year to make up for the postponement. So it really wasn't a postponement. It was a cancellation, right? Or moving to a different system for many of those cases. And this is particularly important. It shines a light on the importance of surgery. And so surgery, a report that we published in the past, is generally about 70% of hospital revenue. So it is a huge driver of hospital financial performance. And when you see a hit to revenue of that magnitude, where really surgery in some ways for some institutions is subsidizing the rest of care, it's very important to focus on your surgical services and to think about that when you're in this type of market where you see these big billions of dollars up and down. So thinking about the impact and how you can maximize then that very important part of your, if you're a health system leader or hospital leader, a very important part of your institution. And these pressures are getting worse by kind of being attacked from both sides. So reimbursements are going down. Anesthesia saw a big hit to reimbursements. And then surgical specialty surgeons, and there's a physician shortage. So there's also a comp increase that's happening as there's fewer demand, those that are in this field are demanding more in some places, and that's creating an additional pressure even outside of COVID. So what do you do, right? What are some things that you can do? And so at the highest level, increase the top line and reduce your bottom line. So how do you do that, right? It's so important, just like people are talking about, attracting and retaining patients. You have to think about that with your own internal, surgeons and staff, right? But how do you attract and retain those surgeons that are bringing in those patients? Make your institution the destination to work and do cases. Also limit same-day cancellations. This is really important. Hospitals, ASCs, it's a lot of fixed costs. So if you have a patient cancel that day because they didn't have the right lab work or the right pre-anesthesia testing, that's a huge opportunity cost for your institution. We do a lot of ROI analysis for our clients, and this is often where you can get millions of dollars of savings each year by reducing your same-day cancellation rate. Also ensure accurate and complete surgical authorizations. That goes to the transparency trend as well. And then improve patient access. A lot of people have to wait weeks to get into their surgeon and then weeks to get the surgery or months. And so what can you do to optimize your own resources? Look at how you're doing block scheduling. If you have a very horizontal schedule, meaning you go very late in the day, there's a lot of add-on cases, how can you redesign those blocks to create a more vertical schedule? How can you make sure that you have the right pre-anesthesia and prep work so that when the patient comes, there's not a cancellation? I talked about the financial implication, but the impact to the patient, right, that's very anxiety causing as well, to have their case canceled on the day of, so within 24 hours. And then how do you tighten your bottom line, get your costs under control? So align staffing to volume. That's very important. There's a lot of data and analytics we'll talk about and tools out there to help you do that. Create more outcome and risk-based contracts with vendors. So as I mentioned, anesthesia is sometimes vended. You have other vendors with materials and pharmaceuticals, and how can you create a more outcome or risk-based contract with those people so that you're aligning the incentives for productivity and access and patient experience, clinical quality outcomes. Also, there's an incredible amount of waste in healthcare, and we're identifying preference cards here. This is just one tactical thing that you can do, is look at your preference cards and when were they last updated, because there could be supplies on there that haven't been used by that surgeon for years, but are still pulled on the tray every time. They're still ordered. They're brought up to the room and either brought back unwrapped, or worse, brought back unwrapped, opened, and then you can't use it again, or you have to wrap it. And so there's all these things with preference cards and sterile processing that really is a very tactical thing that each person can do to help reduce waste. And then better manage add-on cases and overtime with scheduling and efficiencies. So we are showing here, this is a dashboard that we frequently use. It has some of our custom benchmarks. This is helpful for people to see frequently about what should prime time utilization be, turnover time for room time or surgeon time, first case on time starts. It's really important to know this information so that you can help control your cost structure and create a great place for your surgeons and staff to work, and know how you compare to those and have a path to get to where you need to be. So some questions you should be asking about are you using your current resources within surgical services most effectively? Before you go out and buy new things or think about all this new stuff, make sure you're aware of what you have, because you could probably do a lot with people, process, and technology that you have. Look, if financials are an issue, look with what you have first and optimize that. Do you have the data and analytics you need to be able to identify and reduce the waste? So you need to know what to fix and how to fix it. So you need that data to be able to do that. And then is your system and group organized to run in a way to attract and retain top surgical and procedural talent? So once you get your shop in order, you know, what are you doing to improve communication, improve engagement, connect those people with the outcomes that if you're the leader trying to drive, or if you're the staff or the surgeon, how is your leadership doing that to you, or what do you want? So, and are you appropriately billing for the applicable surgical services? Appropriately billing is very important. So Josh talked about telehealth, pre-anesthesia testing. With the changes that have come up through COVID, there's a lot of differences in the way that patients are seeking care, and these are frequently reimbursable. Some hospitals become overwhelmed with just figuring out how to incorporate that into their care plan, particularly with surgery, but also make sure you're thinking about the billing associated with that. And then what new strategies can your organization consider then to make sure that you're being positioned to increase surgical revenue growth at an efficient and obviously the highest quality care. The last trend we'll talk about here is data-driven operating rooms. And it's not new, right, that there are data-driven operating rooms and really cool innovations within the OR. But we want to talk about how that additional things that you can be thinking about in 2021. So I find this stat staggering. So every 73 days, healthcare data doubles. The amount of healthcare data that doubles every 73 days, it is so much to keep up with, right? It's slightly overwhelming. We all have our EMRs. You know, I have my Apple Watch. The definition of healthcare is broader now too, but that's a ton of information. And what does, you know, a physician or a hospital do with all that information to actually turn it from data to insights? And that's a hard problem. And you can see here, there's a lot of people trying to solve it. And 2020, actually, despite the hardship, there was a ton of investment in health tech. So this is important to think about in 2021. If nearly 50% more investment came in 2020 in health tech, just think of all the technologies that are going to be out here now and trying to get into use or that you should be aware of. It's definitely, there's going to be an increase there. That's quite the jump from 2020 to 2019. And a recent survey, too, showed how 87% of healthcare systems are actually looking to invest in data analytics. So a lot of people, like we talked about with margin pressure, you know, people are really reevaluating what you invest in. And so the fact that there are plans to invest more in this space is important. And so what are you investing in and what should you invest in? So this is a little overwhelming at first. Let me talk you through it, right? So this is how data can be so helpful in thinking through surgery and thinking through how you can better organize your day and optimize the schedule. So there's scenario 1 on top and scenario 2 on the bottom. Scenario 1 has a first case on time start delay. So the day just gets started late. Many reasons drive this. We see frequently that it's surgeon delays, but it could be anesthesia, it could be the patient. But there's a delay. So the first case starts late. And these slides, I do believe, will be available afterwards, so you don't have to completely study it now. There's these little carrots on the bottom about, you know, scheduled start, stop, patient in, patient out, procedure start, procedure stop. I saw some questions, which we will get to at the end, but those are important to know when you're talking about turnaround time and case duration. And so the first case happens, and then there's a slow turnaround time. There's a slow turnaround time from patient in to cut, and then to wheels in, and then there's another delay, and then the case, and then a slow turnaround time again. So all of a sudden you're running late. You're probably running overtime by case 5, and you got 5 cases in. Whereas if you look at scenario 2, you have your first case starts on time. Your turnaround times, as we saw in the previous section, around 30 minutes is a good turnaround time, depending on the complexity of your cases. You have good turnaround times. All of a sudden, you look at this day, you're ending on time, huge staff satisfier, patient satisfier, and you got a 6th case in. You know, a huge flaw what people try to do in thinking about return on investment in surgery is they say, oh, well, I saved, 15 minutes this day. So, 15 minutes over time is a whole extra case. You only get the value of the extra case if you save enough time to actually get in a whole case in a particular day. But that's, when you have this efficient schedule and when you have the data and analytics that can deconstruct each portion of your day, each portion of your schedule, that data can be hugely valuable in when the information from that data can be applied through either visualization of how the room is running for that day. I've seen some cool technology there. Or there's great, super interesting AI technology now about what happens between cut and close. That you can now take visuals, take laparoscopic visuals and turn that into data that then helps you define what happens within a surgical case from cut to close. It's very cool. So there's a lot of interesting things happening that help to reduce the cognitive load of surgeons, but also help to improve patient access and get more cases in on a particular day using data and analytics. And that, of course, can be quantified. I won't have to go through this whole slide, but there's a lot of different analytical techniques to actually define the avoidable waste minutes in your schedule and compute those, see how you can get the right schedule, the right information in, and then compute that. So here, there's a marginal case revenue associated with that, with the additional cases that you could get in from my past slide, that's case 6. And then what is the variable labor expense savings by not having, running overtime, or if you had a case cancellation. And so what does then that translate, in this particular instance, this is no particular, or it is a particular unnamed hospital, $756,000 that year, or that month, right, by having better case volume. And so here's some analytics that help look at that, right? So how are you using analytics for your block utilization, for your staffing, for your first case on time starts and throughput? There's a ton of information out there. I always like the one that kind of looks like a high heel shoe in the left, your heat map about how frequently you're running any particular, how frequently you're running particular number of rooms at time of day, day of week, month of year. This data can really help to inform your surgical services flow. So what should you be thinking about? What areas of surgical services could be better automated? Are you making the most of the tools and digital solutions that you already have? Does your organization have a champion and incentives for adopting and sustainably using digital solutions? So when you buy that cool new analytics platform, or you buy that cool new patient engagement platform, do you actually do enough to redesign the process so that you're getting the full utilization of that solution and that you sustainably use that solution? It's so frustrating when you have that cool thing, but it's being underutilized. How are you staying informed about the latest relevant innovations? Like I said, with all that additional money going into health tech, there's going to be a lot of solutions out there. So how do you know who is good, who you should be using for what problems? It's a little complex, and it's helpful to be thinking through that. And then what forms of digital solutions and insights can set your organization apart? So that's important to think about how you differentiate yourself in this organization. So with that, I will, we have all 5 of our trends here: seamless, ASCs, ambulatory surgery centers, transparency, margins, and data. These are the 5 trends to look out for in the surgical services space for 2021. Thank you, everyone, and for Josh and I, thank you very much on our behalf. And at this point, Morgan will go ahead and open it up for questions.
That sounds great. Thank you so much, Leslie and Dr. Miller, for a really fantastic presentation today. Like Leslie said, we'll now begin today's question and answer session, and we've had a lot of great engagement from people and listeners today. So it's I'm really excited for this conversation. If you haven't already, please submit any questions you have by typing them into the Q&A chat box that is on your webinar console. So let's dive into some of these questions. The first question I have for you all is, one listener is saying we have a major problem with case scheduling accuracy, and they're wondering, how do you recommend improving that?
So data is everything, as we have talked about, and this ties to probably a lot of questions people have about, tracking turnover times, first case on time. It's important, I think, initially to have the organization put together this surgical services executive committee, that the first thing they need to do once they get their housekeeping in order is have definitions. So what does first case on time mean? Is it patient in the room? Is it cut time, et cetera? How is turnover time described? And as Leslie said, there's a lot of different markers in the start and end of surgery. It's in the room time, it's anesthesia induction time, anesthesia turnover to surgeon time, cut time, close time, anesthesia out of the room, et cetera. So you have to have those definitions first. And most people are moving to AIMS, an anesthesia monitoring system, and those markers can be identified in the AIMS, and then that data, we extract that data generally for our clients and give them very transparent, accurate data. So for the individual physician who says that their cholecystectomy is going to be 30 minutes, and in fact, Olympic review suggests that their average time is 60 minutes, that's presented to the SSCC, and then their block time is redesigned around their true procedure times.
Thanks for breaking that down, Dr. Miller. Really great question. And we have another one that's specific to COVID. Someone is wondering, is there an estimate of how COVID will impact surgical volume in the next year or two? Are there any statistics that you know that project the expected decrease in percentage of surgical volume due to COVID-related issues? Any insight that either of you can provide on this question would be great.
Sure, I can start with that. I have not seen reliable estimates on that yet, but I think if you look at history, as I mentioned, there was about, we'll just say 20% drop in volume in 2020 due to COVID. Now, in March and April, right, there was each state kind of mandated the postponement of surgery, elective surgery. I don't think we're going to see that at scale in 2021, and especially now with the vaccine out, there's a little bit more optimism. But there are people who, I think there's a couple of factors, right? People don't have this, there's unemployment's higher, so maybe less access to insurance, so lower surgeries. Also, there is, there's a lot of reports out there that people are avoiding elective care because they don't want to go into a hospital because of COVID. And so so that's another factor. In certain pockets of America still, there are huge surges in COVID, and therefore there still is some points in time where certain institutions are postponing elective surgery. So I do think there is going to be a dip really until the vaccine is widely available, a dip in surgical volume. I don't think it's going to be 20%, but I think it is in single digits, but that's Leslie Basham's prediction.
And we appreciate your insights.
I think, Leslie, the only thing I would add to that is we don't really understand fully still the epidemiology associated with the virus. So, as in England, they're stretching the second vaccine to 12 weeks out, and the potential for mutation. And so the bottom line is we really don't know. We believe there's going to be a dip. It's going to be significant, but it's unfortunately good scientists on every side of the questions related to where we go next with the virus have very vastly differing opinions.
Absolutely. Thank you both for weighing in on that question. The next audience question is about using Epic and other EHR platforms. They're wondering what tools are available that interface with, in this case, OpTime, Epic, to obtain the data analytics in a usable and easily digestible format? Is there something that's more intuitive to work with?
Yeah, there's a lot of, there are a few good solutions out there that help with that. So there are ways to do that within OpTime and Epic, or OpTime or Cerner. There are solutions though that are very compatible with them, that make it easier. Our firm, Surgical Directions, has one. There are others, but it really helps to get the data that you need, that surgeons and everyone can understand to make those decisions on block for specialized care teams. So we have one of those tools, and there are others out there that exist really because, sometimes the readability or usability of what's in your EMR may not be to the standard that your organization needs.
That's a good point. And just want to remind audience members on the line, please do still submit any questions that you have. I'd love to answer those with the time we have left. Another audience member is wondering if either of you have suggestions on physician incentivization models.
Josh, do you want to take that one?
So that's a really complicated question, and I was a clinical physician and leader of a system-wide group for a long time, and clinically active for 28 years. And there were a lot of different models we looked at, and I would like to say there's a perfect ideal model. We've used several different models. My personal experience is RVU-based is probably not as effective of an incentivization. It needs to probably be a baseline plus perhaps some financial quality and safety metrics related to average utilization of operating room, pain centers, et cetera. It's really, I think really it comes down to being based on productivity, unfortunately on a financial perspective, or a mixed RVU financial perspective is really the ideal. But a strictly RVU tends to drive a lot of volume, but maybe not a lot of appropriate efficiencies. Unfortunately, because there's a balance between, insured and uninsured, you want to take care of everybody. Dollars tend to motivate people, so you have to find a balance between taking care of everybody and some partial RVU versus some partial direct financial incentive.
Absolutely. And just looking at the clock, we do have time for one more question today. Someone in the audience is wondering, their hospital has a hospital-owned ASC, and they're shifting cases there. Is this causing competition and animosity between the two areas? They're wondering, have you seen similar examples, and what are they doing to overcome this?
Sure. So again, it depends on the demographics of your physicians. Are they employed or are they private physicians? And if they are either, really, but if they're employed and they can go to an ASC and be more efficient, it's actually going to open up time and increase block scheduling for surgeons that say may have more complicated cases and cannot necessarily do them in the ASC. So again, it's about efficiency. It's about utilizing physicians and staff appropriately and putting them in the right peg in the right hole. And if you do it correctly using the data analytics that we've been talking about, and it's transparent in the Surgical Services Executive Committee or other physician governing body, the transparency and the data-driven drive by having appropriate data will allow physicians to appreciate where they are and what they're benefiting from by the ASC expansion, even if they're inpatient type physicians.
And I'll just add too, it's important to embrace this ASC trend. So you could just lose those cases altogether if you don't participate. But then how do you right size your main OR when you do that? And there's a way to make sure the right case is going in the right place, and then making sure that you then adjust You know, if there was a bit of outmigration from your main OR, then adjust your main OR to operate, you know, in a different way, maybe one less room or whatever it needs to be, so that you're still being efficient and there's a great experience in the main OR and in the ASC. And it does create some friction, but it's very addressable friction. But you just need to, you know, have the, like Josh said, the governance structure and the data to be able to understand what's happening and communicate and understand the reimbursement impacts and the staffing impacts so that you can make the right decision for your institution. And we can help with that.
Excellent. Thank you both for those really informative responses, and also to our audience for the wonderful engagement today. It was a really great discussion. So I want to thank Leslie and Dr. Miller just one last time for their excellent presentation and surgical directions for sponsoring today's webinar. If you want to learn more about the content that was presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you all once again for joining us, and we really hope you have a wonderful afternoon.